Welcome back. As we continue our discussion regarding the management of heavily treated multiple myeloma, we talked a little bit about new data in our last segment. Now we really want to focus on selecting treatment and managing the toxicities of this treatment. And there are certainly a lot of nuances around some of these new therapies that are sometimes intimidating to the community physician. I think we are probably not going to see in the immediate future too much CAR T going to community centers. So we'll focus a fair bit on the bispecifics and its potential management in the community. Caitlin, what is your take on the ramp up dosing? Is it something that you're giving in the hospital? Are you potentially going to be giving it outpatient? And what is your take on the ability to transfer this to the community?
So, big loaded question. Our practice here at UC San Diego is our default is to give bispecifics as an outpatient wherever possible. But we know practically and realistically that is not always possible. So I always say, bispecifics and CAR T for that matter, it's a team sport. We really need to make sure we have the infrastructure set up to safely provide these therapies for patients. And that requires that you have obviously the REMS program in place, but that you really have your nursing, pharmacy colleagues, and then you're a specialist with critical care and neurocritical care and infectious diseases and kind of everybody on board. So while these patients are hopefully done as an outpatient, we have an infrastructure set up to get them through step-up dosing, and we can talk all about CRS. But some patients, if they don't have the required caregiver to kind of get them through it practically as an outpatient, if they have comorbidities that worry us that may make their risk for CRS be greater than someone else, or they have perhaps a very big, bulky kind of disease burden, that may be someone who's more at risk for CRS, and we want to have them in the hospital as well. So I think there are certain aspects of care that require probably more careful observation for these patients, but our hope is as best as we can to get them through outpatient step-up dosing. Once they've gone through their step-up dosing, that's where we feel like obviously they can probably safely receive the rest of their dosing as an outpatient, whether that is at the academic center or sending them back to their local community oncologist.
So, Abdallah, what are you doing at Kansas?
I echo what Dr. Caitlin say. That's exactly what we have been doing. One of the things that we utilize, which I think maybe it's about luck, because most of the patients who progress on CAR T cell or receive CAR T cell, we know exactly what happened to them, what's their CRS and the ICANS. So we have a protocol like if they got a grade 1 and they really did tolerate well the ide-cel and they're fit, they have good caregivers. These patients, we do the step-up dose outpatient. We have the infrastructure that Dr. Caitlin has mentioned, and that's something I think it's great. From the studies that we show that the percentage of patients that received tocilizumab and steroids in the bispecific was lower comparing to the CAR T cell. So we feel more comfortable, in these patients. We have seen some readmissions due to some concerns about, grade 1 or 2 of CRS, but these patients have not, have any neurological toxicity. So that have been actually something that we have done. Of course, not all patients who are going to receive bispecific are going to be eligible to do it outpatient. So we still have that concern that we admit the patients with high comorbidities or, patients who have a history or some ongoing plasma cell leukemia, we keep them inpatient, so we have some of these patients that we have to do it inpatient.
Christina, how are you doing it at Duke?
We still are doing inpatient, not because we can't. We actually do the CAR T cell in an outpatient setting. We have the infrastructure in place. We've been doing, as you know, allogeneic transplant in an outpatient setting, even home transplant for many years. And we do have the capability of doing this step-up dose in the outpatient. We actually have a couple of observational beds available. The problem that we are encountering, because our catchment area is provide them with help lodging. A lot of these patients, they cannot come, for 10 days and they don't have lodging support. And that is becoming a problem actually for some of these patients from the community. And so we end up to admit them because the lodging issue, not because we are, don't have the capability of doing and supporting them in the outpatient setting. As I say, we do the CAR T cell all outpatient. But we have that issue. We have people traveling a few hours away, and so a lot of people cannot, afford lodging for 10 days or so.
So Gurbaksh, I know you're in the process of moving institutions or have moved, but how have you managed your bispecifics to date as far as the ramp up goes?
So at my previous institution at UT Southwestern, we did mostly inpatient ramp up, but we sort of did an expedited one when it came to teclistamab. It was not, we did, I think it's a 5 versus 7 day thing. And that went really well. We did not see a lot of severe CRS. I think as I was leaving, there were discussions of sort of figuring out, sort of as Abdullah said, which patients could we do as outpatient? And even the consideration of giving prophylactic tocilizumab. But those were ongoing discussions. So far, we've reserved for doing a lot of inpatient. And I think similar to what Dr. Gasparetta said, a lot of our encatchment area in the North Texas area is, it's so wide. So resources, lodging all become an issue. And if someone's on talquetamab, are you going to make them come 9 days in a row from far away to do this outpatient? So I think those other considerations end up playing a bigger role as well in terms of deciding who to do inpatient versus outpatient.
So obviously there was talk about prophylaxis probably in the future that may make it a little more feasible for some community practices also to venture doing this. What is your take on this right now?
Actually, before I get to prophylaxis, that might add to the complexity for the community, actually. So we do things a little bit different because we are a true community practice. So the hospital is dissociated from the community practice, right? And a lot of times it comes down to finances. So each practice is going to have to figure that out. So what we do is we actually dose as an outpatient, but then admit to the hospital for observation, and it's a separate entity. So the patient then discharges, comes back to our clinic, gets dosed, and then goes back to the hospital. So they're kind of going back and forth. And that's sort of the best way for us to do it. And so we have a practice has like a big catch area as well. So we decided to do 3 of our clinics to be the specialty clinics to be able to try and kind of improve that distance for any one patient. So that's how we chose to do it. But yes, I think within the practices that are doing the step-up dosing, the question often comes, can we do it as an outpatient? I would love to do it all as an outpatient. And I think the idea of using prophylaxis is great. And I do believe in prophylaxis. I'm actually a big proponent of using toci early in our patients, not only because it resolves CRS immediately, but if you look at the studies, it basically prevents recurrence of CRS in those patients that have received the toci. So that's an even bigger sort of reason, other than, of course, the problem, of course, being the price. But I think the data with prophylaxis looks fantastic. The reducing rates of CRS from 70 to 80% to about 30%.
Yeah, so moving on to a little later in the course, obviously we'll come back to infections in a minute, but just dwelling on some of the unique toxicities of talquetamab, skin, nail, and dysesthesia. So what are your observations, Christina, and what pearls of wisdom do you have on management of these toxicities?
So you see, they're very difficult toxicity to manage, very difficult because we don't have much, right? So I've been reviewing publication and my experience. So we try to actually counseling patients before, particularly nutrition. They develop the dry mouth and the dysgeusia because they targeted. And so, teaching them to use solution, dexamethasone, nystatin. Sometimes we use nystatin for several days. And then we tell them, to keep sipping fluids, go around, sipping. Some patients will use a lozenge before a meal, for instance. And I've seen that a little bit everywhere with the skin, a short course of steroids and steroids creams, and the nail is very difficult too. How can and there is it doesn't happen right away during the step-up dose. It happened probably at the beginning of cycle 2 or 3, and for some patients is a problem. I had a patient recently send me a lot of pictures, and she was very upset, afraid that the rash was going to her face and the nail, so they're For us, sometimes say, okay, you're losing the nail, but you are, responding. And talquetamab is a very powerful drug with a response of 70%, but it's affecting their quality of life, not capable of tasting food. So it's difficult. If I look at the ratio at Duke, first of all, because it was approved after teclistamab, I think we still use a lot of BCMA, and so maybe 1/3 talquetamab, and we're still trying to figure out how to manage this type of toxicity. It's not like the major toxicity that can kill you, but can be devastating for some patients.
So any nuggets there, Abdullah?
Well, I mean, I'll tell you, this is talquetamab, with this side effects. I'll tell you the efficacy, it's really amazing. And unfortunately, these side effects are the causes. I'll tell you, the dyschezia and loss of appetite are the main causes why patients stop the treatment. Even if they're responding to that, they request, I don't want to do the treatment anymore. Regarding the skin side effects, I've been using the ammonium lactate lotion even before it starts. I always advise patients use it, and I've really start seeing a lot of luck, and it's kind of like amazing, like how much that really helps. For the dyschezia and for the oral toxicity, I have no luck except to dose reduce it, decrease the frequency. These are the only ways to actually decrease that side effects. And some of the patients, when they stop it, it took them like, unfortunately, months for their taste to come back again, So it's really an amazing treatment in terms of efficacy. I have patients who have went to renal failure and they're about to go dialysis, and in 1 week after the step-up dose, this treatment get them back to remission, kidneys back to normal. And there is a price, unfortunately. I wish we have better way to manage the toxicity of this other than decreasing the frequency or stopping the drug. I think this is going to be a really great treatment in the future. I think it have a potential to be a combination therapy in the future to have more efficacy and better duration of response.
So Caitlin, what are you telling those patients that are going back to the community? What are you telling the community docs about how to manage things?
So fortunately, if these side effects happen, they happen. I've noticed in my group, it happens soon. It happens early. It tends to happen kind of within the step-up dosing, perhaps. So hopefully the kind of worst of it has happened while those patients are with me. We now have some of this data that told us how we can successfully decrease the frequency and decrease the dose if we need to help mitigate some of these side effects a little bit. So I think depending on the severity of the side effect profile, we can either keep the patient on, and over time, this will get better. But for some people for whom it's so severe, you really need to back off a bit. And I think the best way to do that is to decrease the frequency of the drug. And I think that is kind of an ongoing conversation as the patients go back to help us understand how they're doing. I agree. This is a fantastic drug. It works very quickly. And that's why I particularly like it for bridging. And I will actually give like I give the step-up dosing, the first treatment dose, and then I stop because they nosedive so quickly. And then I want them to get their performance status back if they lost it from the talquetamab. But I worry that moving this drug up closer to the front line or an early relapse is going to be more challenging. Our later relapse patients have a much higher tolerance for side effects than perhaps our, newly or early relapse patients who are still working full time and have, lives that they really need to continue. And I'm not sure the tolerance for a side effect profile like this is going to be as acceptable earlier on.
So Gurbakhsh, are you telling your community doctors anything different?
No, I think Abdullah and Caitlin have sort of covered most of the things that we see. I think I actually echo Caitlin's comments 100% that this is a drug that's very effective, but it's kind of going to be challenging to move it up front because of the toxicity profile, but it's very effective.
So yes, it's obviously everybody says it's an effective drug. It also produces pretty fast responses. So do you think that that is a positive and you can somehow manage the toxicity because if you've had a response, it's been there fast?
Yeah, no, I do, and I echo everything everybody said. I think this is the perfect candidate for a limited duration of therapy, right? So we're talking about an effective drug that has toxicities. The one thing I will say is what's really important is patient and physician education. So if you're anticipating that this is going to happen, the patient's more likely to not panic, to not sort of to try and figure out how to deal with it. So I've had patients, because we participated in the phase 1 trial, so we had patients very early on And, when we started seeing these without even knowing that was going to happen, it was very traumatic. But then as sort of kind of patients started seeing this and we would start telling them about it, we even had other patients that were willing to talk to those patients who were just starting about the toxicities there were and what kind of things they did. And so that's what I would encourage is just like, don't have the patient and their treating physician sort of be blindsided by the toxicities, because I think that's the hardest part. If the patient's anticipating it, the majority, sadly, like Caitlin said, these patients in relapse refractory setting, they're willing to tolerate more toxicities, and most of them actually do tend to stick with it until we get to the dysgeusia and the weight loss, where I agree that's a tough side effect.
Regarding infection, is there any difference between the BCMA bispecifics and the GPRC5D bispecifics in that regard?
So I think what we know from some of the data is that the BCMA target seems to be associated with more of an infectious profile, more so than GPRC5D and talquetamab as an example. And so while it's incredibly important that any patient getting a bispecific antibody be prophylaxed with IVIG early on. I usually get them through step-up dosing just so that there's no overlap with IVIG kind of infusion reactions. Once the step-up dosing is done, immediately put them on IVIG. And the intention is to maintain them on monthly IVIG, basically as long as they're on the drug, and perhaps even afterwards if the drug is stopped, to maintain IgG levels. Because these patients who are getting T-cell redirecting therapies become T-cell deplete, extremely hypogamma. Their B cells to some degree are wiped out just the same. And so they're really immunocompromised. And so we think that it's likely more common to see more infections and weirder, stranger, more kind of, strange infections, just like we heard earlier, PJP, weird viremias. I think the most critical thing is that you have a high level of suspicion for infections. And the patient who comes on a bispecific antibody who hasn't fevers is not going to just have a pneumonia. You really need to think outside the box for these patients and thinking about the more unusual infections that could be occurring.
Christina, any different perspective?
No, I still run on the allogeneic service. And so it's very similar to how we manage patients after allogeneic transplant, right? Prophylaxis, antibiotics we use from out of the gate, like I mentioned, IVIG, like Kathleen said, and sometimes we educate, we remind the physician to subtract the total IgG, the myeloma IgG to the total IgG, so there is a continuation there, keep the level above 400. PJP prophylaxis with Bactrim. Sometimes we see myelosuppression. So we use pentamidine, atovaquone, antiviral, and then for the first few months, also antifungal, fluconazole, and antibacteria. Other antibiotics like levaquin sometimes, and then the monitor of these viruses, the CMV, particularly like in the allo setting. I mean, so we check particularly patients with protracted pancytopenia. In the allogeneic, we see some of the virus playing a very important role, HHV6, CMV, HSV. So we're kind of, for an allo perspective, they're very similar patients, very immunocompromised. So yeah, a lot of educations jumping immediately at the onset of fever, particularly if it occurs later on in a setting of neutropenia, etc.
Della, you'd already mentioned your own heightened sensitivity to infections. Anything to add to that?
No, I have to echo what both Dr. Caitlin and Dr. Christina have mentioned. I mean, what I also here try to as much as do is something, I just make sure the patients, with these weird infections to be up to date in their vaccines. I have a low threshold to give these patients growth factor shots if they're neutropenic. The infection rate is really high and real. Like if these patients got an infection, I tend to actually call ID consult, make sure that all the workup is done. If these patients need a bronchoscopy, just to make sure they're not having any atypical infection, I highly recommend that. These patients, they can have any type of atypical infection that could increase the mortality. So these are the things I try to do, of course, in addition to keep these patients on IVIG and any kind of prophylaxis in order to prevent any further infections to happen for these patients.
So he says, are you monitoring for CMV?
So I'm not monitoring for CMV on everybody, but if they have a fever, immediately we check and that's part of the workup for sure. And I'm not prophylaxing for CMV. I think, I echo what everybody else said. I think being vigilant is important, and I think prophylaxing is important. And I agree with Dr. Costello. I think IVIG, we need to use it a lot more aggressively. I think some of our guidelines that say wait till you're under 400 or have infections have sort of been a problem from an insurance standpoint. And I think we just need to give it to everybody. Remember that patients with IgG myeloma may have high IgGs, but they're malignant IgG, so they're not actually normal IgG. And so unfortunately, sometimes those patients get under utilization. But no, I think that I'm doing what everybody's doing. I will say though that I do agree that the BCMA agents are more likely to be plagued with infection than the GPRC5D, but they both are. So I think we still need to be really cautious with the GPRC5D agents, and we still have to be looking for the same things. You know, hopefully the rates are much less. But both are, I think the message to at least to the community docs is you need to be vigilant with all of these agents.
Do these patients need revaccination though?
There's no right answer. I don't know the answer to that question. But actually what I try and do is, if at all possible, if the patient's not exploding, is to actually get them to vaccinate before you start. So if the patient, you know, if it's flu season, make sure they get all of their seasonal vaccines right away. Make sure they get their Shingrix, their pneumococcal vaccine, if at all possible, before you start. There's, especially with the BCMA agents, there's very good data that the suppression of B cells is so profound that the response to vaccines once you're on therapy is actually quite limited. I still give patients vaccines, but knowing that they're unlikely to get the same protection.
Gurbaksha, are you doing anything different?
I religiously give IVIG. I'm very much on top of it from the moment these patients get started on bispecific therapy. I don't vaccinate for, revaccinate post bispecifics. I do post CAR T. And we, at my previous institution at UT, we used to check routine CMV monitoring in bispecific patients, but we did not do prophylaxis for them. But really good about doing PCP prophylaxis.
Not relevant too much to the bispecific discussion, but some discussion has occurred in the CAR T realm on secondary malignancies. Jesus, what's your take on the secondary malignancy? Is it giving you pause for using CAR Ts?
It's not giving me pause for using CAR Ts, but I think it is a real signal. And I think that the question becomes whether it's truly the CAR T itself or if it's the patient that's already at risk. But definitely even just looking at that, and I think there is definitely an increased risk of secondary malignancies, especially myeloma malignancies with some of the BCMA CAR T products. Now, we haven't seen that yet with the bispecifics, which is interesting. And so the question becomes whether we will, because that sort of became a signal later on. And it goes back to one of those things where I think real world data becomes especially interesting, is really following those patients long-term and then getting that long-term data for toxicities that we were not aware of that in the clinical trials because the reading was so early and so forth. But no, I think it is a real signal. I think the benefit of CAR T still way outweighs the risk, but it is something that we need to stay vigilant about and talk to the patients about.
So, Caitlin, as far as these secondary malignancies go, it was hinted that it may be the targeting of these targets, or do you think it's more to do with lymphodepletion, exposure to fludarabine, pre-existing clones in these patients that are heavily pretreated?
I agree with Jesus. Well, actually, I should say this. I really like to see the FDA report that said we might have overestimated or overstated the risk. So I was grateful to see that because I think there was a big buzz about how we were causing so much potential harm to our CAR T patients. But these are game-changing CAR Ts. They've changed everything for our late relapse patients. So I think like the same conversation we have with our melphalan auto patients, where we're starting dealing with the devil we know or the devil we don't. For me, the benefit so much greatly outweighs the risk of that the conversation happens, but in my mind shouldn't dissuade someone from going through it.
Gurbaksha, what is your take on the secondary malignancy story?
I mean, I think it's real, but whether it's, the myeloma patient also has years of other treatments on. So I think you can't just blame the treatment that comes right before that. There's been years of Revlimid, there's been Mel-Auto, there's been so many other DSEP and other alkylating agents. Like there's so many insults to the bone marrow throughout this process. So I think it's just hard to blame it on one thing. I don't think I have any qualms about it recommending CAR T to late relapsers at all, because this is a game changer, as Caitlin has said. These patients in this era, in this stage of their disease, did not live as of 3-4 years ago. So now we have therapies that have impressive results. I think even in first or second relapse patients, now that CAR T is approved earlier, I have this open and honest discussion with the patient. In the patients who have truly high-risk disease and who are like functionally high-risk, relapse rather quickly post transplant, I think the pros are always going to outweigh the cons in terms of doing CAR T earlier. Now, somebody who's been on 10 years of Revlimid maintenance and now relapses, should they go to, CAR T in second line, or should they go to something else standard of care, such as darapomorolidumab or dexamethasone? And I think that's where the sort of the real risk and benefit discussion ends up around being this topic. The signal's there, but how much of a big deal it is, I think long-term data and follow-up will show.
So, Abdullah, what would you like the community physicians to take away from this segment of our discussion?
Yeah, absolutely. I mean, I think there's many things that all colleagues, I cover a lot of things, and I think management of the toxicity of infection and for the BCMA and GPRC5D, it's something very important. One of the most important things is to reach out to the academic centers to share the guidelines. I think that's really very critical. Developing some kind of workshop, always going to be beneficial for our oncologist colleague in order to get up to date about all the new stuff and all the real management for these toxicities. And I think because bispecifics, we have 3 approved, FDA approved bispecific in myeloma. And I think we will, in the future, I think the combination therapy is going to happen. And so most of these community oncologists are going to have to deal with side effects, whether they are early side effects or while on maintenance. So we have to kind of develop a way to make sure our colleagues in the community oncologists have access to academic center algorithms that they can share and be updated in that regard.
Christina, what's your key takeaway for the community physicians?
Yeah, it's about the same. We're actually in North Carolina. We started to have roundtables with the community physician, how we can bring these drugs out in the community, because ultimately they need to be available for all our patients with myeloma. And so, as I say, the education, how these busy community physicians can follow and properly these patients and avoid, like a devastating infection. If it's possible, we don't want to lose patients for other reasons, if it's possible. So yeah, I continue, I guess, collaboration, and now that we are increasing our experience, we need to be committed to educating our physician in the community to best manage these patients. I agree.
Caitlin, what's your words?
My take-home point to hammer home is 4 letters: IVIG. Do it early, and do it indefinitely, as long as these patients are getting these drugs.
Isis, you get the last word.
No, nothing new. Just I agree. Prevention and vigilance is the key, because these are amazing drugs and we need to use them appropriately.
There's a lot to think about here, and thank you for all of you to share your insights. And we will look to see what is next coming in this highly refractory space in the next segment. Thank you.